acetaminophen or Tylenol primarily exerts its action in the CNS, resulting in net effects of. Okay, we're treating pain. Fever, good. Okay, true or false? Tylenol carries box warnings for increased risk of GI bleeding and cardiovascular events.
False.
False. Why? It's NSAIDs. Okay, don't let me trick you on the exam. Venlafaxine is an SNRI antidepressant useful in chronic nociceptive and neuropathic conditions. True or false? True. So our SNRIs are helpful in both. Our TCAs are primarily helpful in neuropathic. Good. So our TCAs are tricyclic antidepressants. What are some examples of TCAs? Doxepin, amitriptyline, nortriptyline. Okay. Good. They should be used cautiously in many patient populations and are contraindicated in which setting? Suicidality. Okay. True. What else? Memory. Okay. So those are all precautions. Cardiac. So if they have a recent MI, we cannot give TCAs. Okay, that's the concern as to why we don't give it, and we're precautioning people that have memory problems and suicidality because we don't want them to get these cardiac complications. All right, and then anticonvulsants primarily useful in nociceptive or neuropathic? Neuropathic. Good. All right, take a second going through muscle relaxants, others, talk with your partners about these as well.
Yeah, it's true.
Alright, we'll start walking through these, hearing these wrap up. True or false, cyclobenzaprine or Flexeril exhibits anticholinergic effects and is an analog of diphenhydramine or Benadryl.
True.
Seeing some truths, seeing some falses. So does it have anticholinergic effects?
Yes.
Yes. Is it an analog of Benadryl? What is it an analog, or what is it like? TCAs. Tricky.
Definitely
Okay.
true.
Which one is an analog of Benadryl? Or phenadrine. Yeah, I think I told you guys that I've never seen it before. Literally this morning I was working on our new patients for this afternoon, and we have a patient coming in who's on it. So we have to go through that case. Baclofen works as a blank agonist, one of the agents used in muscle spasticity, such as MS. GABA B. Good. All of our other ones that work on GABA are on GABA A. Okay, so our benzos, our barbiturates are on GABA A. We need to ensure close monitoring since tizanidine may cause what type of toxicity? Hepatic. So liver toxicity with tizanidine. What other ones can cause liver toxicity? So circle back to those, right? We have that one chart that has the high risk, medium risk, low risk. All right, NMDA receptor antagonists inhibit postsynaptic glutamate signaling. Not bad. Glutamate is a what type of neurotransmitter? Excitatory neurotransmitter. Okay, so if we inhibit that excitation, now we no longer have that pain signal. And then true or false that conotide or Prialt is derived from snail venom and is administered via intrathecal pump. True. What is its weird side effect? If you just take a bunch of venom, you might be a little confused. Okay, so CNS confusion is going to be that main side effect. It is dose related, so we can come down on the dose and it's fixed. Okay. Questions from part 1 or part 2? So we talked about this very first section, kind of opioid overview, right? Lots of different mechanisms. We naturally have opioids within our body. When we activate these different types of opioid receptors, we can get different effects at each of those when they're activated. Remembering that some of our opioids have a mixed effect at these different sites as well. Namely, buprenorphine is going to have these odd things where most other traditional opioids are full agonists at mu. And then we have our antagonists with naloxone and naltrexone as examples. Opioids, we should always be thinking of using our IRs in acute pain situations, only giving our long-actings when we have a patient who is tolerant to opioids already. There's many non-pain conditions that we can use opioids for, and then for pain, all different types of pain, but mainly it should be limited into these patient populations. Chronic long-term opioid therapy is not demonstrating functional benefit, and the FDA is currently looking into it. And then remembering that we have different dosing strategies. So we can dose the opioids kind of as this ocean. As a long-acting, we can give these waves and treat those with immediate release opioids. Calculating all of those together will give us our total daily dose. We can have someone getting a continuous rate, whether that's via a patch or an infusion. And then patients can also, when they're in the hospital, can get a pump that has a push button on it. And so that could be useful in some patients as well. Again, the guidelines kind of summarize some of these points that we talked about in those slides, and then just that girls section there. Moving on to tolerability. So these are really going to tie back to the different mechanisms that we talk about as well. Right? So going back to that, I think, second slide that talks about when we activate the receptors, these are all the anticipated outcomes. So common side effects with opioids, we have GI as a big notable one. So nausea, vomiting, constipation. We can also get a histamine release. That's most commonly going to happen at which of our opioid receptors? So mu is most commonly when activated to have that histamine release. CNS depression, and then respiratory depression. If we're on opioids for a really long time, we can get things like decreased libido, decreases in mood. We can actually increase our fracture risk. So a number needed the harm of 25. So definitely increases in those that are using opioids. Immunosuppression, that number needed the harm is about 16. And then increased cardiovascular event risk, and that doubles or increases your risk 2.4-fold. So these are great things that if I get a patient in clinic who's thinking about coming down on their opioids, they want to start to come off of them, they were unfortunately put on them for something that was inappropriate, and were able to control their pain in other means. Now they just have that tolerance to opioid therapy. A lot of these long-term side effects are things that I go back to in counseling to help motivate that patient. If we have any sort of tolerability concerns for opioid therapy, things that we can do is we can either reduce the dose. These are going to be largely dose related. We can switch from one opioid to another opioid. We could switch the route of opioids, right? If someone's taking it orally, they're going to get more of this histamine release, more of this GI side effects, versus if we put it into a pain pump, they're only going to get the CNS side effects from it. Okay? So we could pick a different route of opioid, or we just manage the symptoms. Okay? You have constipation, we give you a laxative. You have itching, we give you an antihistamine. So again, these are some of those side effects. So for nausea and vomiting, it's seen fairly often, so 30 to 60% of cases have some sort of nausea and vomiting. It's very much self-limited. So right when we start it and whenever we increase your dosing, we're gonna see this nausea and vomiting come up. We can give them an antiemetic, so something like Zofran or others to help with that in the short term. If someone is constipated, the mechanism of constipation with opioids is that we're actually stopping that peristalsis. Okay, so in the gut we have mu receptors. When we sit on those, we no longer have that peristalsis going. So we actually need to give a stimulant laxative, okay, specifically a stimulant. So osmotics, stool softeners aren't necessarily going to give that same benefit in these patient populations. We can also do a peripheral opioid receptor antagonist, which is good. We'll talk about on the next page. Histamine release. So again, these are a couple different things that might exhibit. So we have this vasodilation, we have a risk of hives, other things that are going on here. And our big question is this a side effect because they're on opioids and opioids can cause this release of histamine, or are they having an allergic reaction? Okay, if they're having an allergic reaction, we need to not be using this chemical anymore, right? If they're just having a histamine release, we can give them, for side effect management, we can give them an antihistamine. Sedation and grogginess, typically this means that we reduce the dose. In the palliative care setting, this is where we might consider giving them a CNS stimulant. Okay, so it sounds counterintuitive, but in some of our patients where they're terminal or where they really need to get that pain control and opioids are the only way to do that, we're giving them both opioids and Adderall or something else like that to stimulate them from a CNS standpoint. Respiratory depression is certainly the most serious, and that's going to be the fatal concern in opioid therapy. We're going to stop opioid therapy, and then we can use central antagonists at those opioid receptors. And then if someone has opioid-induced hyperalgesia, what does that mean? Have you guys heard of that before? Hyperalgesia? Okay, so have you guys heard of the word allodynia? Ooh, midterm day. Okay, so allodynia is I brush a feather over you and you are in tears crying. It hurts so much. Okay, so allodynia is pain to a non-painful stimuli. Typically, if someone has a scar, they'll get allodynia at the scar site. So we do like scar deactivation type stuff to kind of numb it. Okay? Hyperalgesia is an increase in pain to a painful stimuli. I punch you, it used to hurt before, now I punch you and you are in tears on the floor. Oh my gosh, how could you do that to me? Okay? So it's a unique consideration with opioid therapy is that we give you opioids to treat your pain. You come back to clinic a week later, pain is so much worse, everything hurts, all this stuff. So what do? You increase their dose. They come back the next week, oh my gosh, everything hurts, it's horrible. Doc, help me, I tried to double my dose, it still hurts. And so it's a very unique phenomenon that happens with some opioid therapies where we really need to evaluate, is increasing the dose helping or is increasing the dose hurting? And it goes back to this hyperalgesia standpoint. So how we actually treat it is reducing the dose of opioids and their pain gets better. So it's a pretty quick trial that you can do with folks, but it is something that you have to get that buy-in. Oftentimes I see this in the hospital where we're seeing it occur. All right, so talking about constipation, where we're having these mu receptors in the gut that are getting activated and are stopping that peristalsis, we can use a peripheral opioid stimulant or a peripheral opioid antagonist. So methyl naltrexone, okay, keyword is methyl. Methyl naltrexone is a peripheral antagonist, and because of that methyl group, which is just a carbon, it can't cross that blood-brain barrier. Okay? So because it can't get into the brain, that means that you still get all the good effects of the opioids, helping the pain, helping everything else that's going on in the spinal cord, while everything in the periphery is getting antagonized. Okay, so that's the effects that we want in this situation. Mainly we're going to use it for that opioid-induced constipation, and we can either take it oral or sub-Q, roughly similar in pricing, but fairly expensive compared to some of our stimulant laxatives. Should you use methyl naltrexone if some random person is constipated? No. Okay, I see this probably once a week. Okay, oh, they're constipated. We'll give them methyl naltrexone. That works for constipation. Okay, mechanistically, it's only working on those opioid receptors. Okay, so if those opioid receptors were fine before, you're not going to change anything after. So let's say we have Harold. He's newly starting opioid therapy for severe cancer pain. He wants to ensure that he is able to maintain a high quality of life and minimize any potential concerns associated with therapy. So firstly, is opioid therapy appropriate for Harold? Why? Okay, so he has severe cancer pain. Okay. What side effects might we expect could happen if Harold starts opioid therapy? Nausea, vomiting, constipation, okay, potentially CNS and respiratory stuff, right? Making sure that we're counseling on those things. What meds might we consider giving him as well as he's starting treatment? Okay, so naloxone, we'll get to that in a couple slides. Antihistamines maybe, good. Stimulant, laxative, nausea, good, right? So thinking about some of the side effects we might be experiencing, making sure that we're counseling on that, right? When you take meds before, do you typically get kind of nauseous from them? Yes? Okay, we're going to get you something for that. Constipation is always going to happen in our patients, so that is one that we need to make sure that we're giving that stimulant laxative for. Okay. All right, moving on to some precautions. So certainly precaution in pregnancy and lactation. I'm not going to get into much more detail than that. Those that have pulmonary function and then those that have head injuries. Opioid therapy can lead to different types of respiratory depression. So now we have carbon dioxide or retention, and now we're having more vasodilation, and so we're just getting further and further damage in those that have PVIs. So that is a concern for those that will be deployed or on the front lines. In pediatrics, the two opioids that I want you guys to be aware of are going to be codeine and tramadol for CYP2D6 ultra-rapid metabolizers. So both of these things metabolize into more potent opioid therapy. And so the concern is that if they metabolize that transition really quickly, right, now they have a lot of this really potent therapy. Okay? Codeine goes to morphine. Now we have a ton of morphine, because we just quickly metabolized it via 2D6. So we actually have a box warning for codeine in kiddos that are getting mouth tonsil type procedures. It's contraindicated for tramadol in that same population, and then contraindicated for both of those in less than 12 for any procedure or consideration. And then there is a warning recommending against its use in 12 to 18 in any patient population that would have concerns for increased opioid side effects, right, if we had excessive amounts in the system. The prevalence of a 2D6 ultra-rapid metabolism pathway is roughly 10% among all different ethnicities. Okay, so it is certainly something to consider. So remember back to Mr. Milo. 10-year-old getting an extensive dental procedure, expected to be severe pain and persist for a few days. He'll initiate non-Pharms. I think we had talked about maybe some NSAIDs and other things as well for him. What opioids are we going to potentially not consider for him? Why? So he's a 10-year-old. He's getting a dental procedure. Right? Two things that we probably don't want little Milo to have to experience. Okay. So avoiding codeine and tramadol. Are we going to start a long-acting opioid for him? Just put him on a fentanyl patch, call it a day, like he's fine? No. So what type of opioid therapy could we start for him? Just the breakthrough, just that short-acting, just the IR or the immediate release. Some additional precautions, so certainly renal and hepatic impairment. All opioids carry risks in both of these categories. I have not required that you guys necessarily memorize which CYP enzyme each one is related to. Just know that they do have different CYP enzymes and they do all carry different risks in these populations. And then looking at these two different charts, so we have renal failure on the one side and then hepatic impairment on the other side. Which opioid is preferred in both of those? Fentanyl. Okay, which one is not recommended in both of those? Codeine. Cool. Fun facts to know. All right, REMS and box warnings. So REMS is a requirement that different manufacturers have to ensure that they're appropriately educating providers and patients and making sure that they have good med guides. So med guides are a thing that the pharmacy must dispense with every single prescription that the patient picks up. So med guides are required for antidepressants, and they're also required for opioids and then a handful of other drugs that have other kind of unique side effects. So my bias is I feel like med guides are very stigmatizing, that every single time you pick up your opioid prescription, you get this packet saying opioids are dangerous, all these things, oh my goodness, right? So sometimes I do like to counsel my patients, hey, when you go to the pharmacy and pick this up for the first time, right, Mr. Harold, I'm really sorry that you got cancer. You're going to go to the pharmacy, you're going to get these meds, it's really going to help with your pain. They're going to give you this packet of information. Everything we talked about, I think, will be sufficient for us. Okay? But legally, they are required to give that to the patient. The patient can't refuse it and hand it back to the pharmacy. The patient must take it. The patient can then throw it away, but they physically have to take it. There's box warnings for addiction and misuse, respiratory depression, accidental ingestion, neonatal opioid withdrawal syndrome. So when baby is born, kiddo can go through withdrawal if mom was using opioid therapy throughout pregnancy or prior to delivery. And then there's concurrent risks for other CNS depressants, so either being benzos or things like alcohol. And then, like I mentioned, box warnings with concurrent CYP blank inhibitors, right? So we're increasing that concentration. Some definitions to be mindful of. So tolerance, dependence, and addiction. Tolerance is a statement that means that the medication dose needs to be higher, needs to be increased. I'm tolerant to 4 cups of coffee a day, and in order to get that same baseline, I need to go up to 5. Okay? 4 cups is no longer cutting it. I need more. Okay? So your body adapts to it. Dependence is that you're stable with that current amount, and if it were to be taken away, you would go through withdrawal. I'm on 4 cups of coffee a day. If I go without tomorrow, I am very clearly dependent on coffee. These are the exact same ways that I explain it to my patients. Right? I fully expect that at some point in your journey, you are going to be dependent on opioid therapy. You're going to become tolerant to opioid therapy, and we will need to increase that dose. Addiction is specifically that they are seeking out opioid therapy despite known harms. They're doing it during work hours. They're avoiding family functions to go and get opioid therapy. So addiction is specifically doing it despite those negative outcomes. If someone truly has addiction and they have what we call opioid use disorder, there's a couple different treatment approaches that we can take with it. So per the guidelines say we just recommend that you treat it. We don't care how you do it, so long as you do it with one of the preferred medications. So there's 3 options that we can do. One is methadone. Methadone is a C2. Buprenorphine, we've kind of talked about, has this unique mechanism, right? It's a partial functionality. Bup is a C3. And then we have naltrexone. Naltrexone is a mu opioid receptor antagonist. So just based on their mechanisms, if someone has opioid use disorder, how are these going to feel for each patient? Okay, so take a second, think about each of these, and then talk with your partner. So assume you have a patient who's using heroin every single day, right, worst case scenario, every single day they come to you and say, hey, I need help. I have opioid use disorder, help me out. So think about each of these. How is it going to make the patient feel? Talk with someone next to you. Come up with a choice of which one you want to start for.
this agonist that'll do the same effect as opioids. Make them, there's still a reaction going on. I think they still maybe feel high or feel good. And the naltrexone, I think,
So it's
a mitigation, but not
it's kind of like a calm down in the sense of like, which is kind of like
right.
what is that? Or give us like conviction or like tightening down.
Yeah.
It's just blocking that thing. Hopefully, try to help with the create.
That makes sense to me.
Alright, there's no right answer. We're gonna do a show of hands. So pick which one you wanna do for this patient, right? No right answer. Guidelines say there's no right answer. Nicole has her own biased opinions. That's Nicole. So who wants to do methadone for their patient? Handful. Okay, who wants to do bupe for their patient? Couple. Who wants to do naltrexone? Handful. It's pretty split. Okay, so let's think about the differences. Okay, if you're on heroin, heroin is going to be a full agonist. Right? Which of these is a full agonist?
Methadone.
Methadone. So I think of methadone as you're using heroin, now you're using prescription heroin. Okay? You're just doing a one-to-one type thing. Okay? Don't dose it as a one-to-one. That would be horrible. Bad idea. Don't do that. Heroin is in grams. We don't do that. Okay? So it's just a one-to-one. Okay? Bupe has this partial mechanism. So what's going to be its pros and cons?
Non-stimulating.
Kind of a step down. Maybe not as much of a high. Yeah, so, right, having that partial effect, we're not going to get as much of that CNS, some of those other things. And we'll get into these a little bit more. Okay? Naltrexone is going to be a full antagonist. So how's your patient going to feel? Yeah, so if they haven't started withdrawing yet, they're not going to like you. Okay, if they're high and they're dependent on this thing, and now you completely block those receptors, they're crashing and going through withdrawal immediately. Okay, so whenever we use naltrexone, we always have to give a little bit of a window. We need to have them suffer through this withdrawal, swap them over. Okay. So let's talk about it. Naltrexone, Vivitrol. So it's a central mu receptor antagonist. Largely, we're going to use it for opioid use disorder. We can also use it for alcohol use disorder. Mechanism is a little bit unique there because we're just targeting that mu. We can also use it for other types of use disorders, so methamphetamines. And then we can also use it for itching, specifically itching related to opioid therapy. We can give it either orally, that's going to be for alcohol use disorder, or an IM injection. It's going to be monthly. Some patients may need it to be every 3 weeks, depending on their level of cravings. Contraindicated whenever we're initiating therapy, we need to make sure that we're waiting 7 to 14 days from their last use. Okay, so we need them to detox from their opioids first, then we can block the receptors. Okay, the benefit of choosing this is that then if they start using heroin, hopefully that naltrexone is going to keep those receptors blocked. Right? I keep saying heroin, but any opioid is also going to do that as well. Meaning that we need to ensure that these patients have appropriate pain management during painful procedures. So if they're taking oral, they would need to stop 3 days prior to needing opioid therapy. If they're taking the injections, they need to wait at least a month prior to taking opioid therapy. Okay, someone's getting their hip replaced, they're probably going to want some opioids for a day or two, right? So we need to make sure that we're allowing their body to clear this blocker so then the opioids are working. If folks are getting this, we do encourage that they wear a medical bracelet stating that, because if EMS or someone picks them up and they're trying to control their pain, they're going to wonder why this person's still yelling. Okay. So we do encourage wearing a medical bracelet. And it is possible to overcome the effects of this therapy. You just give a ton of opioids, and they typically will get admitted to the ICU, get respiratory support, all the 9 yards. So summarizing this section, Per the guidelines, this touches on regular follow-up whenever we start therapy, right? Thinking about those side effects, talking about those things, making sure we're appropriately monitoring them, using caution whenever we're using with other opioids or CNS depressants, and then ensuring that we're treating, managing, and supporting patients that have or develop an opioid use disorder. So if we have little Tony, 75-year-old male, he has newly diagnosed metastatic cancer. He's been offered opioid therapy to manage his severe cancer-related pain, though declined, stating, I don't want to get addicted to that stuff. So firstly, is opioid therapy appropriate for Tony? Yes, why?
Cancer.
Severe cancer pain, good. What would you tell Tony? So we can talk about other options. What was that? Ketamine, cool. I would question how we're going to do that on an outpatient basis. But I do like the thought, okay? What else? Do you think Tony's going to get addicted?
No.
Probably not. So, right, do I think that Tony's going to get to the point where he's using opioids despite known harms? Probably not. Do I think he's going to become tolerant to opioids and dependent to opioids? Probably. So this is a lot of my counseling in our poly clinic, talking to folks about, I bet you see on the news a lot of folks that have addiction and misuse or these other things, right? I fully anticipate at some point, if you tried to stop your opioids, you're going to feel a need to try them again, right? I think that at some point we're going to have to increase because they won't be cutting it anymore. It doesn't mean that your cancer is getting worse. It just means that your body's getting used to it. So knowing those differences, tolerance, dependence, and addiction are unique considerations when counseling. Okay, we have Kenzie, 30-year-old female, opioid use disorder. She's interested in trialing something to help mitigate her ongoing cravings. Okay, so if she solely has cravings for opioid therapy, she doesn't have pain, she doesn't need to replace that opioid receptor to get that high, if you will, this might be a good candidate, just knowing off this one line, that naltrexone may be appropriate. We just need to occupy those receptors. We could also use our other therapies. So in summary, side effects, precautions, and management with those. So thinking that tolerability concerns with opioid therapies are common and should be managed appropriately, either through a dose reduction, a rotation to something else, or manage. Opioid therapy may be influenced by both renal and hepatic function to include specific CYP enzymes. Tolerance, dependence, and addiction are key definitions when discussing controlled substances like opioid therapy, and patients that develop opioid use disorder should be appropriately managed with a treatment approach that best aligns with their situation. Moving into opioid safety, so thinking of overdose, reversing, risk mitigation, what to monitor for, and then coming into a taper or a withdrawal picture. So when we increase our dose of opioid therapy, so whenever we have a positive influx of this opioid agonistic action, we're going to see this progression. Opioids kill you in overdose, not in withdrawal. Okay, so things like alcohol are killing you in withdrawal. You seize, and that's how you die with alcohol. Opioids kill you because of the respiratory depression in overdose. So opioid overdose is the concern. Things that increase your risks, so if they've had prior intoxication situations before, if they have prior overdoses, if they have a history of substance use disorder or illicit drug use, if they're concurrently on other CNS suppressants, the higher the dose that they're on, if they have any baseline renal or respiratory compromise, and then renal and hepatic impairments. And then indicators that might suggest that we are nearing an overdose situation is that they would have slow, shallow, or no respirations, difficulty to arouse, whether we're doing voice or giving them a nice old sternal rub. They're going to have pinpoint pupils, that's going to be for our mu agonists, and then blue lips or fingertips. So we want to reverse that So what we're going to do is use a central antagonist. Okay, we want to get into the brain, we want to reverse it centrally. We're going to compete for those opioid receptors, and we're going to displace those opioids that are already there. Okay? Mainly we're going to use these for opioid reversal. We want to give these similar to the analogy of a fire extinguisher. Right? We hope we never have to use this, but we're going to have a fire extinguisher on hand just in case it were to arise. Same thing with these reversal agents, just in case. If patients really don't understand that one, I'll talk about EpiPens. Most folks understand that, especially if they have an EpiPen themselves. My personal viewpoint is oftentimes these aren't used for the patient. Okay? Often this is loved one, family member, babysitter comes over, finds opioids, takes opioids, and they're the ones that need that rescuing response. Certainly if folks live remotely, and then if they request it and they just want it, they can have it. They are available over the counter now for intranasal. So we have intranasal, we have sub-Q, we have IM, we have IV options, and then our side effects are going to be a withdrawal picture. Right? If you were on a bunch of opioids, now we reverse it, now you're going through withdrawal, which we'll talk about here in a second. For the nasal spray, the approach that we do is we evaluate the patient, shout their name, do a sternal rub, assess for overdose, what's their breathing like, what do their pupils look like. We're going to administer a dose, then we're going to call 911. Okay, we're not going to delay care. It's going to take EMS the same amount of time to get here, whether it's 30 seconds that we called them before or not. Okay, we're not going to delay that 30-second dose. So these come prepackaged. You kind of peel off the top of the lid. It's in a little container. Take out the nasal spray. The plunger is on the bottom. So you just put the top part into the nostril, press the plunger all into one nostril. You place them into a recovery position on their side. Call 911, initiate rescue breathing if you need to, or CPR. And then you can give additional doses every 2 to 5 minutes until help arrives. So the boxes that have the nasal sprays come with 2 nasal sprays in them, so hopefully that's roughly 10 minutes of support for the patient. So we're going to talk about 2 different agents. One is naloxone, the next page is nalphamine. So naloxone is a central antagonist. We're going to use it mainly for opioid reversal. We can use it for other conditions. So in considerations, that first bullet there, oral administration is really non-existent, so less than 2% bioavailability, meaning we can give it orally, it can get into the GI tract, and it can reverse locally those effects of the gut. Okay? So instead of spending $100 a day on methyl naltrexone, we can spend pennies and give them IV formulated naloxone orally. Pretty cheap. So we do that at MAMC quite frequently. We see these different observations here. So different products. What are the general thoughts of these times? Love them, hate them? You have a patient, they're dying in front of you, and the onset of your nasal spray is 3 to 17 minutes.
Good number.
Okay, so when you spray it, is your patient going to hit you right away? No. Okay, so that's a big misconception with a lot of these products. Certainly there's nuances and one-off cases, but it's going to take time for these drugs to start working. So another counseling point, right? They're not going to respond right away. You still need to call 911 and do all these things. How about the duration? 30 minutes to 2 hours. Some thumbs up, some unknowns. How long do most of our opioids work? I know we haven't gotten there yet. Okay, so long-acting certainly longer. Right, hours. So most of our short-actings, I like to think of, right, we're dosing them like every 4 to 6 hours if you guys have ever kind of seen them in practice, if you've ever gotten them personally for a procedure. Right, so they're lasting that long. So if someone sees someone found down, they don't want to get caught by the cops, but they nicely administer naloxone. Hopefully they come to, they flee. This poor person is potentially going to go back into overdose in 30 minutes. Okay? which is why we need to make sure that we're calling 911. All right, nalmefene, not to be confused with nalbuphine, also is this mic open? Okay. Also is used as an antagonist. It has higher affinity than naloxone, meaning it's going to bind to the receptors better than naloxone does. It's used in opioid reversal, but it is not indicated in our kiddos, so only 12 and up. What are your observations about these pharmacokinetics?
Quicker, longer.
So faster onset, significantly longer half-life. So that duration is going to be much, much better. Okay. DHA asked for my expert opinion, and I told them obviously replace Narcan with this. This is 10 times, million times better, right? If it was my kiddo, I don't care that it's not indicated in a 2-year-old. I want it to work 20 minutes faster. I want it to last hours longer, right? DHA said no. So I tried to die on that hill. Here we are. You guys have the option to use both of these as an IV. Certainly if you're worried that someone's going to leave against medical advice, giving them something that's longer acting is going to help mitigate that risk of potential coming back and having an overdose event. All right, little Felix, 6-year-old, has no pertinent past medical history. He's found down, his weak pulses, slow and shallow breathing, cyanosis of the lips. No family member in the home is presently receiving the support of hospice and is requiring concentrated oral morphine solution. Yeah, not a fan. These situations happen. So what is our concern? Overdose of opioid therapy with morphine, good. How are we going to reverse it? What mechanism do we want to use to reverse this therapy? What mechanism of action? Central mu receptor antagonist. Okay. And then we have our variety of choices. All right, general risk mitigation. You give someone opioids, right? All the folks we've been talking about that we say, you know what, opioids are appropriate. There's different things that we can do for them. So things like toxicology screens, whether it's getting a urine sample or blood, we can actually look at the different chemical compounds that are in their screens. We can do prescription drug monitoring program reports. So DHA or the DoD has one. Every state has their own database as well. And you can just run a report to verify what pharmacies have filled. If a patient is getting prescriptions as a sample from a provider's office, it will not be on the PDMP. So it's only pharmacy fills. You can get a physical pill count. So looking at the availability of their meds. Is a person stockpiling and they come in with 4 bottles of their oxy that have been the last 4 months of supply? Doing that physical count can be helpful. Opioid agreements or sole provider. This is some sort of contract or education that you can have with the patient. Some, depending on what site you're at, may or may not be legally binding. Okay, so essentially your contract would say, I'm the only person that would prescribe these to you. If you have an issue, that doctor needs to contact me, and then we'll work on it. But some sites, if that's violated, that doesn't mean anything. Okay? There's different screening tools that can be done. So ORT, SOPR, and CALM are some that you may hear when you guys are in practice, and then just different times that you would do it. So if you're initiating opioid therapy, you would do either ORT or SOPR. ORT is an objective screen that you look at their past medical history and you decide what their risk of opioid misuse is. SOPR is giving them a form and they fill it out, and based on their score gives you their risk. So it's like history of this condition, that condition. Have you ever been to an AA meeting type thing. COMS are another subjective thing, but it's when we're continuing opioid therapy. They've been on opioid therapy for a year, you give them a COM, it comes back saying that they're high risk for opioid misuse. That would certainly make you reevaluate. We can also do screening tools to determine how effective opioid therapy is. So the PEG screen is is a subjective screen that we can do to figure out how functional the patient is with opioids. We can do respiratory safety screening. So the Reassort is a numeric objective calculation. Most sites have it integrated within the medical record, and it just tells you what their risk is. And then naloxone rescue, certainly we just talked about. Whenever we taper, so now we're thinking about kind of that withdrawal side of things. Tapering would say, you know what, these aren't helping you, you're at risk for misuse, or maybe you just don't want to be on these anymore. That's totally fine. Whenever we do a taper or wean, the goal is to reduce the total daily dose of opioid therapy. And it's going to depend on the situation and the goal of the wean, maybe for either just reducing or eventual discontinuation. The guidelines have two statements, meaning that they suggest using a collaborative approach when weaning off of opioids, and that there is insufficient evidence to recommend for or against a specific way to do it. So they just say, if you want to get off of them, talk with other people on your team, and there's no right way to do it. Okay, really helpful. Specifically on the CDC guidelines, so those are just the VA, DOD guidelines. The CDC guidelines recommendation number 5 has a couple points to it. So when you should taper is if benefits do not outweigh risks, we should taper, right? Too much risk, not enough benefit, we should come off opioids. Opioid therapy should not be discontinued abruptly unless there is risk for life-threatening issues or warning signs of an overdose. Right? If they are actively overdosing, we need to reverse them now. If they are exhibiting really aberrant behaviors, they're seeking stuff, they're doing things that are not safe, they're selling their meds, right? Those would indicate maybe we need to come down a lot faster. We need to use shared decision-making and making sure that the patient has agreement and interest in doing this. So again, think of it similar to smoking cessation. You're not going to get very far if the patient's not on board with it. The common approach that is used, and this is per the guidelines, is doing a 5 to 10% reduction of that total daily dose and doing that every 2 to 4 weeks. Certainly, if folks have been on therapy longer, they might need a slower reduction. My favorite thing to ask patients when they come to me and they're motivated to come off is I ask them, when do you think would be a good goal? And time again, they say less than 3 months. I'm like, how interesting. My goal is 1.5 years, right? You've been on these therapies for 20 plus years. You're on super high doses. My goal is 1.5 years, right? We want to prioritize minimizing withdrawal symptoms. So that's why I have such a long schedule to mine. For patients that have withdrawal, they're more likely to rebound and go back up to those doses that they were on before. So what does withdrawal look like? It's non-fatal, but it's going to feel like you're dying. Okay. Abrupt discontinuation can cause withdrawal. It can persist for a few days to weeks, depending on the prior level of dependence that they were on, the prior dosing that they were on as well. And then those that have unmanaged withdrawal symptoms are at higher risk of relapsing overdose in the future. So that's what I was mentioning. How do we manage withdrawal? So we either replace the opioid, right? We came down on your dose, you're going through withdrawal, well, we'll just put it back up. Usually we don't recommend that, right? We came down for a reason. So typically we'll keep it down. We can manage the symptoms, give them something for that side effect that they're experiencing, or we can do any other sorts of supportive care, right? So if a withdrawal effect is nausea, vomiting, we can give them an antiemetic. All right, 2 more slides here. CDC guidelines, again, the things that we just talked about with going up and down on dosing, making sure that we're weighing risks and benefits of therapy and considering tapering when appropriate. We have regular follow-up. We mitigate risk of opioid therapy and offer naloxone, that we do PD&P reviews, so those state fill history reviews, and then consider toxicology testing in subacute and chronic pain states. In summary of these section, making sure that opioid reversal is administered if someone may be actively experiencing an opioid overdose event. Risk mitigation and monitoring may include incorporation of different talk screens, performing pharmacy dispensing reports, and then screening for misuse, efficacy, and safety. And then opioid tapering approaches should be patient-specific and minimize those opioid withdrawal symptoms. Questions? All right, we're gonna go for break.
You know about it.
You graded your paper? You have that one. No, I know, but mine didn't do that. I wish you would have. Can I look at it? See, I wish you would have done that.
Not everyone doesn't like. Mine just wrote like
Literally, the only thing was like,
yeah. Also, most of my stuff was just like dramatic stuff. It wasn't like
it was what?
just dramatic stuff. Like, give me a 97. So, I don't know what else I could have turned.
Mine wrote a bunch of garbage.
Wait, you see, you can literally turn it in like that? No, the template for the actual thing is different.
For the final?
Yeah. I looked at what they have for it. No.
Maybe the grading.
I look.
It's different.
Are you sure you're not thinking about the presentation? That's remember, senior year we did the actual presentation.
Oh no, I looked at a sample for the final paper, and it looked totally different. Like it wasn't like it was different.
Like a newsletter.
Oh.
I read it.
What was it about?
A bunch of random. Like packets.
For what's competitive pack?
Talk about like the average. I think it's just a general.
But like that's more the station. Like that's a student. Like why would the students write that? You don't fucking know how they do this. I know. I'll just like I got to blow my nose in tea.
After going through that,
Oh, man, I got track fast.
I feel like my time is supposed to right out, dude. Oh, is that feedback?
Time I could tell a difference.
This is just where you have 70 points. I don't see a difference between this one and this one.
Rio and Timber. You're going down. Going. Are you yelling timber at least? I haven't smelled your coffee. I saw making it here.
We try to walk in the same stall. Somebody left I'm gonna strip it down.
Yeah, the only difference is if I went back and forth. The only difference is like now it's out of 70. So like that's why the points that you have to make like you have to go from like 5 points to 30 because like you make your changes. So like outside of that, like the only difference it's all worth
Since I looked at the stamp, no, I didn't look at it.
Oh, there's the whole now like 46. All you're doing is just to adjust what it's allowed to see. So it's a rough draft, right? Yeah, that's why you're not so your time. But if you do such a good job in your rough draft,
Bring it back here. That's not what I'm.
Here.
it's like the way you get to go. What were you looking at?
Alright, I understand that you guys are tracking tomorrow for Pharm. We're not doing Pharm tomorrow. Class has been canceled. Okay. In lieu of that, I'm going to get as far as I can. We will do that on Monday when I come back. We may have to finish a few slides. Okay. After that, Monday is a review day. If you guys have questions, I'll be here. Okay. I do want you guys to know that in the website, whatever it is, right? There's 2 different worksheets. Okay, so one worksheet has a single page summary of all of the slides, right? All 300 slides. Has every section, has what the slide numbers are, how many slides total that includes, and then a brief overview of what was discussed. Okay? And then it has 3 pages of random questions. I will not be posting the answers. Okay? So this is partially if you don't want to come in person to a review session, great. Here's that. Potentially at the review session, I anticipate that we may talk about this. Okay? The other worksheet that's in there is going to be an opioid conversion calculation, which is the last part of what we'll get to, which may get pushed to Monday depending on how we do on time today. Okay? So there's a summary overview on the first page of, hey, little refresher, and then again, 14 example questions. Okay? The answers to these are posted, but the math to get the correct answer is not. Okay, so it just says, oh, this answer is 60, but it doesn't tell you how I got to 60. Okay? Questions on these 2? I know last semester was the first one that I started doing this. Is my mic still working? It's cutting in and out. Okay, you guys yell at me. So last semester was the first semester I did this. I know previously there were like written notes that one of the instructors used to give, like summarizing. Maybe? No? Cool. Okay. If you do have written notes, the reason why I made this was because there were a couple of errors that I would say were in the prior lecture groupings that we'll talk about here today as well. Okay? Questions? Now we're going to talk about all of our different opioid agents, noting that I didn't put opioid agonists because some of the opioids that we talk about aren't full agonists. Okay? First, we need to understand how are all these opioids connected. So we have all these different chemical structures. When we think of opioids, maybe you guys have thought of like opium or the poppy seed, right? Maybe that comes to mind. So that's where opioids are originally from. Whenever it's from the opium plant, we call them opiates. Okay, so this is that little red box in the top corner. Opiates are derived from opium. Okay? Opioids are the broad umbrella of things that resemble the effects of opium. Okay? So an opiate looks like opium. Opioids work like opium. The first column there of our different drug classes, this is our morphine structure. These are going to be our most opiate-like, most like opium. So morphine is that structure there, and we see a whole host of other opioids that are in that list, right? So if someone has anaphylaxis to one of those, do we want to put them on another one that's in that exact same pathway? Probably not. Why, right? Allergic reactions are based on that chemical structure. So it has that same chemical structure in that same class. The risk for a sensitivity risk is high or probable. As we continue to go further and further away, we have lower risk of cross-sensitivity. So that's just what that scale on the bottom means. Okay, in the second column, we see loperamide. What's loperamide used for?
Poop.
What?
Poop.
Diarrhea. Okay, I'm like, what are you saying? Diarrhea. Okay, how does it work for diarrhea? Mu receptors in the gut, right? So we're just giving an opioid to the gut. That's all. if you take enough of it, right? If you go to a retail pharmacy and buy 30 boxes, I guarantee the pharmacist is going to have a couple questions for you. So people do that with the intent that if you take enough, you'll get CNS effects. Your gut will also hate you, but you'll get CNS effects.
Oh,
Okay.
yeah.
Fentanyl is in that middle column there. Fentanyl is one of our synthetics. Meperidine is also in that column as well. Methadone is a whole other class there, and then tramadol is in that last grouping. So really our biggest concern is kind of this first column here. And so one of the ways that I like to think about it are the different metabolism pathways. So, alright, so we're just going to look at this top section for now. So when someone takes codeine, codeine metabolizes into morphine. Morphine metabolizes into hydromorphone. Codeine also metabolizes into hydrocodone, which also metabolizes into hydromorphone. Okay. Heroin turns into a unique metabolite called 6-AM. 6-AM turns into morphine, turns into hydromorphone. Okay? This is my abbreviated summary of what that just says. So heroin goes to 6-AM, goes to morphine, morphine goes to hydromorphone, codeine, hydrocodone, codone, hydromorphone. So C's always go to M's, codeine goes to morphine, hydrocodone goes to hydromorphone, and everything gets hydrolyzed. Okay. So it's alphabetical, C to M, C to M. Your second one, you add an H. Okay. Oxycodone goes to oxymorphone. Love our C's to M's. Okay. Methadone has a lot of metabolites, but they're all inactive. Loperidine has some, tramadol has some, fentanyl has some. Okay. So whenever we're thinking about this pathway, we need to be thinking about if someone fails one therapy, can we try another therapy and expect it to work differently based on its metabolites? If someone takes hydromorphone and they say it doesn't do anything, are we going to try morphine? Probably not. Are we going to try codeine? Probably not. Okay. Vice versa, if someone says codeine doesn't do much, could we try other things down the line? Maybe, right? Maybe they have an issue metabolizing to morphine, right? So maybe we could try something else. So we can look at it in terms of efficacy. We can also look at it in terms of tolerability, right? If someone has a rash to morphine, does that mean they're always going to have a rash to hydromorphone? Maybe not. Will they always have a rash to codeine? Probably. It's always going to turn into morphine. Okay. Whenever we're doing different labs, we need to ask the patient about what their total dose was and when their last dose was that they used. Okay. They take oxy and you get a urine on them and it comes back negative, right? You need to figure out, is that appropriate? No, I've been taking it 4 times a day every day. This is weird. Okay. Or vice versa, right? Don't stop someone's therapy just because we didn't ask when their last dose was. This is another way to look at it in a table format. So we have our opioid. We have its inactive metabolites in that first white column there. We have its active metabolites in that next column. Again, we just did this on the last page. Morphine goes to hydromorphone. Hydrocodone, or hydromorphone goes to nothing. Hydrocodone, hydromorphone. Okay? We also have other active metabolites. If you guys have an interest in pain management, you will learn to love all these, or hate really to love all these other active metabolites. Many of them have more side effects. And so that's a big part of how we're choosing different opioids as well, based on these other active metabolites. And then the 2 that have no active metabolites are going to be fentanyl and methadone. Okay? Did we prefer either one of those in our prior slides when talking about renal and hepatic? fentanyl. Okay, maybe that makes sense. We're not worried about its metabolism. We're cool. All right. This is just another example, and then some of the different substrates, inducers, and inhibitors that we've talked about so far throughout these slide decks. Okay, so again, 2D6, 3A4 are going to be our most prevalent. Methadone we see is touching on everything, and then certainly 3A4 is going to be our most common CYP enzyme that drugs are going through, but then we also do have our 2D6s. Now we have Edward. Edward is a respectable 45-year-old male. He got a short course of tramadol therapy for his acute pain. He was notified by his employer that he was randomly selected for a tox screen. Sucks to be Edward. So his employer does what we call a Federal 5, which looks for opiates, marijuana, cocaine, amphetamines, and PCP. His findings are currently pending. What do we believe are going to be his final results?
Federal jail.
So they're going to be present, not present. So this goes back to that one fancy term. What is an opiate? Like opium. Okay, so your opiate screen is only going to tell you if it has the morphine and other submetabolites in that C's to M's pathway. He's taking tramadol, right? On that grouping was tramadol in that first column. Tramadol is far and the other thing, and as we talk about tramadol, tramadol doesn't play like the others. Tramadol looks nothing like the other opioids. So is his opiate screen going to be positive? No. So his total results should all be negative, right? Not present. Questions on Edward? Yeah.
Just to clarify for myself, so the first page on this opiate pathway with all the different compounds, the far left morphine panel, that's the only opiates. Everything else is an opioid.
Yes. So your first column are going to be the most opiate-like, most like opium. Okay. Morphine is a direct metabolite of opium. Then when we're doing this pathway, right, for morphine, those in that top section, this guy here, right, these are going to be more of our opiates that are positive. So when I was civilian practice, we would have docs that would fire patients because their urines were negative. You told me that you're on tramadol and all these things, like no more, you must be selling it. Dude, get the right lab, right? So, very much my vibes. That why are we having this person go through withdrawal, potentially seeking opioids elsewhere, just because we're not ordering the right test? So understanding these things can be helpful. Good question. Other questions? All right, this is based off of one of our patients. 40-year-old female receiving chronic opioid therapy. She's on methadone, 10 milligrams by mouth, TID, oxycodone, IR, 5 milligrams as needed. So methadone's going to be basal. It's a long-acting, and she's on a breakthrough therapy. Her urine toxicology screen was recently completed and came up with these results. So looking at these, think about if it's appropriate, talk with the person next to you, appropriate, not appropriate, what you think could have gone wrong or awry. Alright, so should methadone be present? Yes. Should oxycodone be present?
Yes.
Yes. Should anything else other than oxycodone be present?
Oxymorphone.
Oxymorphone. C's go to M's. It's still an oxy. Cool. So should fentanyl be present?
No.
No. Tramadol?
No.
No. Morphine?
No.
So what about this hydromorphone? Hey, I hear someone say she's doing heroin. Could she be doing heroin?
Morphine.
Could she?
Codeine.
Morphine is not there.
Codeine.
Could have metabolized long enough. Could have. Or she's just taking hydromorphone or
Hydrocodone.
hydrocodone. Okay. So this patient, me and the doc were so up in our heads. We certainly had a little bit of bias going into this case, right? Like, oh, we're gonna fire her, all this stuff. And then we're like, you know what? She just said she was in pain. Did she go to a civilian ER and get a push of Dilaudid, which is hydromorphone? Because that's standard treatment, right? She did. Okay, so it's appropriate, given the scenario. It was an appropriate window for her to come in. Okay. So we were ready. All right, we're going to start going through the different agents now, kind of going through that metabolism pathway. You'll see on the top what class they're in, and then you'll see on the bottom where they fall in that metabolism pathway. Something in your slides will kind of be covered up gray. That's because I want you to understand like the gist of it for your own knowledge, but not that I'm going to ask you like, is it 1 hour or 2 hours? So heroin, it is a mu receptor agonist. It is more potent than morphine. It has no medicinal use because it is a C1. It's an illicit substance. And then remembering metabolism goes to that 6 a.m. byproduct. So that's how we can determine if someone's using heroin or not. Currently, we have a patient who has admitted to using heroin. They've done urine drug screens that have been positive for morphine. They're currently undergoing litigation, but there's no confirmation of 6 a.m. So this person also is concerning for psych distress, potential secondary gain of like, hey, just fire me type thing. And so if we don't have a true 6 a.m. positive, we can't definitively say that they're using heroin. Okay? So very interesting stuff that we're dealing with over at PMC. Codeine, moving on. So codeine is a weak mu receptor antagonist. It is less potent than morphine. Codeine has variable controlled substance classifications. So when it's by itself, it's a C2. When it's with acetaminophen or Tylenol, it's a C3. I think of that, the brand name of that is Tylenol number 3. And so that's why it's a C3, is how I remember that one. And then when it's with guafenicin for cough suppression, it's a C5. Some considerations with codeine. So it does have an actual respiratory irritant as one of its byproduct pieces. So I always think it's interesting that we use it for cough, even though it has this coughing irritant to it. And then metabolism, like we mentioned, it goes to morphine, and then it does have a box warning in that metabolism pathway, like we talked about, especially with our kiddos. We see that there's PK/PD, but again, just want you to know the gist of it, that yes, it's going to work within an hour, it's going to work for a couple hours. And we'll see that with most of our opioids. All right, morphine is a C2. It has primarily mu receptor agonism, some delta, and less so kappa. It comes in a variety of routes. ER formulation is called MS Cotton. Please note that per Joint Commission, MS is an unapproved abbreviation. We don't want you to confuse it with magnesium sulfate. That would be really bad, right? Give this patient some MS to help them out, implying magnesium, and instead they get a bunch of morphine. Consideration for itching, GI, and then CNS depressive effects, and that's just because it's that primary mu receptor. These are some of those other metabolites that I was talking about. So M3G, whenever there's a 3G, 3 I think of CNS, also 3 letters. We have our CNS side effects with this 3G metabolite. M6G helps with pain, and then hydromorphone is one of its other metabolites, and that's also going to help with pain. Morphine, you can see its long-acting therapies look like candy. So this is one that sadly does have many of case reports of kiddos eating these. Hydrocodone, C2, also we can use this for cough, equally as potent as morphine. We can have it combined with a variety of other things, but it's not going to be used by itself. So it's always mixed with either any of these other products here. Again, codeine can go to hydrocodone, and then hydrocodone can go to hydromorphone. We do have an ER formulation available, but we rarely use it. Same thing with hydromorphone. We have an ER formulation. Rarely do we use it. This is going to be more potent than morphine. Oral is by far the most common route, but we do have IV, rectal, and intrathecal as well. Consideration, so this is another one that has a 3G metabolite. Again, more CNS effects, more of that hyperalgesia, that opioid-induced increased pain response that we can see with this submetabolite of hydromorphone. Questions with this first grouping of our opiate-like agents? Oxycodone, so now we're getting into a little bit of more of a unique mechanism. So now we're getting both mu, but we're also adding in serotonin. So now that we're having serotonin activity, we're going to be at risk for serotonin syndrome. Okay. We have a variety of formulations for this one. So we have oral, both IR by itself or with acetaminophen, and then we can also have an ER formulation. You can see in the shading there, right, the peak effects and the half-life effects really aren't that much different. ER therapy is marketed as a 12-hour formulation, but it really has a half-life of roughly 5 hours. So part of, I don't know if anyone's followed the whole Pharm, right, Netflix series and wherever else, I think every single streaming service has their own variation of it. But part of their marketing is very smart in that they used an agent that doesn't have a long half-life, marketed as a 12 hours. Patients go through withdrawal before their next dose, so they're more likely to use. It's also serotonergic, so they're going through serotonin withdrawal as well. So two very uncomfy things. And so oftentimes in our setting, we'll dose it 3 times a day to help with that duration barrier. A couple weeks ago, I had to call a pharmacy to educate them about why we're dosing it 3 times a day when it's marketed as a 12-hour. So much misconceptions, unfortunately. Questions with Oxy? All right, so we have Kevin. Kevin's a 58-year-old male. He has an upcoming elective painful surgery. He reports a historical reaction of itching with morphine and wants to ensure that his pain can be appropriately controlled intra and post-operatively without worsening the general tolerability of therapy. What could we do for him? He's having tolerability concerns. So I hear potentially rotation to something else. Okay, hydrocodone or something like that. Could we give him codeine? Why can we not give him codeine?
Breaks down morphine.
It's going to go to morphine. Okay, so we're not going to give something before morphine. Good. So we can rotate to something else. What else could we do? What was that? Okay, something that's further downstream from morphine. Okay, so still picking another product. But if we said, you know what, we're a cheap institution, we're only going to give you morphine. And histamines, we can treat the response. Okay? We can also dose reduce. Okay, so whenever we have tolerability concerns, remembering that we have other options, whether it's going to another product, treating that symptom if we can, or lowering that dose. Okay. So we're ideally avoiding codeine morphine, potentially using hydrocodone or hydromorphone, and then likely maybe even using something else, oxycodone, oxymorphone, or some of the other things we haven't talked about just yet. Okay, Miss Anna, 33-year-old breastfeeding woman, has new onset cough associated with a suspected viral illness, looking to suppress the prevalence in the short term of her coughing. Benzonatate, love it, just like opioid lecture, not, nope. Okay, so what are the two that are indicated for coughing that have little images of the person coughing? Codeine and hydrocodone. Okay, so your two C's are for cough. Love that. Okay. Let's say we give her codeine with guaifenesin. Any concerns? Okay, so if we have codeine, if she's in 10% of the population, that's ultra rapid metabolizing over to morphine. She's breastfeeding babe, high levels of morphine now. Babe is at risk for an opioid overdose. And those are other cases that are frequently reported. Very, very sadly. I would say this is most concerning. We have a couple folks who are breastfeeding and are maintained on opioid therapy. For them, it's just a matter of ensuring that we're not going to formula for a couple days. Babe is going through withdrawal during that time, and then we're going back to breast milk. Now we're going through a withdrawal and then back on those concentrations. So we do a lot of counseling on doing appropriate tapers for those situations. All right. Moving on to some of our other classifications. So we have fentanyl therapy. This is one of our synthetic options. It also has serotonin. It is more potent than morphine, but we now have this risk for serotonin syndrome as well. Our injectable solutions are going to be for acute use. We have a transdermal patch in all red, all caps, asterisks, all the things. Do not give it to opioid naive patients. This is a hill I will die on. So let's talk about these patches. These patches are clear. Horrible product design in my opinion. A clear patch would go onto the skin. It states the drug and then the dose that is on the patch. You apply the patches either to the outer arm, across the chest. You can apply them kind of to the side area. You can apply them to the low back around the flank as well. Ideally, no hair in that site. Clip the hair, don't shave it. You will increase absorption, as we talked about back in topicals, right? Our dosing is that we're going to do a patch every 72 hours. It's going to take roughly 6 hours for the patch to start working. Okay? I put a patch on, it's going to take 6 hours for it to get into the bloodstream. Meaning if I'm on a long-acting before, or if I'm on other opioids before, or if I'm in the hospital on a drip, typically we don't stop the drip until 3 to 6 hours into the patch being on. Because they're not going to get any pain benefit the second you put a patch on. Okay. When we dispose of patches, we're going to fold them, we're going to flush them down the toilet. We don't want to put them in the recycling bin. We don't want dogs or kiddos to get them, put them in their mouth. Okay, what's going to happen if you have a fentanyl patch on a mucosal membrane? Superabsorption. There's roughly 70+% of drug in the patch once it's removed. So there have been cases of that as well. We do not cut fentanyl patches. Fentanyl patches will lead to dose dumping. Okay, this is a 50 microhour patch. If we cut it because we needed a 25, we've had cases of our nurses at BMC doing that. Put them on the patient, pharmacy didn't have it. So here we are. The patient is now at risk for immediate opioid overdose. Okay, you're getting a patch that normally you get 30% of the drug over 3 days. Now you're getting half of it all at once. Okay. So we never cut fentanyl patches. What type of patches can we cut? Lidocaine patches, all day. Fentanyl patches, we also have a unique box warning for, again, similar to what our topicals we talked about. Whenever we have an increase in heat, whether it's internal, the patient is fevering, they're exercising, or external, they're going into a sauna, they're going into a hot shower, We can get an increase in fentanyl concentrations, roughly 33% increase. So we had a young patient, would always feel so great with a warm shower. Like it, whenever I take a warm shower, it just really helps my pain down. Yeah, I bet it does. I don't think it's the warm shower. I think it's the, bump dosing that you're getting in fentanyl during that time. There are some other fentanyl derivatives. So sufentanil is going to be more potent than those products. Remifentanil is a unique one. So this one has a really rapid onset and offset. It's metabolized within the blood. So it doesn't go to the liver to get metabolized. Your blood enzymes actually break it down. So it's really, really helpful during procedures that are super quick. Give a dose, do intubation or whatever you need to, and your blood eats it up. Okay, meperidine, also known as Demerol, has the lovely nickname next to the trash can of dumped Demerol. It has all the mechanisms. So we're at mu, we have anticholinergic, dopamine, serotonin, norepinephrine. We also have some weird sodium channel blockade. Awesome, love this. Off-label, we're going to use it for post-op shivering. We can get rigors if someone has AMP-B concerns. Its place in therapy is not to use it as an analgesic. Has a long half-life, and it has box warnings with MAOIs, given its multiple mechanisms. All right, tramadol. Again, now we're going all the way to the far side with tramadol. This is going to be a weak agonist, and again, serotonin. It's less potent, so again, we have more risk of that serotonin syndrome. This one will lower that seizure threshold as well, and then a lot of those different metabolism pathways, as we already talked about, especially in our kiddos, that 2D6 ultra-rapid metabolizers. All right, now we got Josh. Josh is a 34-year-old. He cares for his elderly mother, who is actively receiving the supportive hospice. Her pain is well managed with the use of fentanyl patches and concentrated morphine oral solution. She is eating very little, and Josh hopes to cheer her up with her favorite turmeric tea. What's wrong? Some 2D6 stuff, maybe? So we're worried about metabolism issues. What's wrong with metabolism? Yeah, so turmeric can potentially slow down metabolism, right? Inhibiting metabolism and causing some sort of overdose. Okay, so if we're not able to metabolize fentanyl, now we have more fentanyl, potentially not great. Okay, we're not metabolizing morphine, all those things. Okay? All right. Methadone. So now we have two unique cases. So methadone is going to be one, and then we're going to go to bupe. So methadone we talked about already. For what patient population could it be helpful for? It's one of our three choices for opioid use disorder. Okay, so not necessarily withdrawals. So opioid use disorder. We have mu, delta, and kappa. We also have NMDA receptor antagonism. So things like ketamine, okay? We also have serotonin, and we have norepi. So this is essentially morphine plus ketamine plus duloxetine, right? A 3-for-1. So I love methadone for that reason. I hate methadone for a lot of other things that we'll get to. We do have risk for serotonin syndrome with this one. When we're using methadone for pain, usually we're using low doses, less than 40 milligrams. Okay? It's more helpful in kind of a mixed neuropathic pain than other opioids because of these other mechanisms, specifically that NMDA. when we're treating either withdrawal or opioid use disorder, that's typically going to be in higher doses of methadone. Not always, okay? But if someone comes into the hospital and their family member says that they're on 200 milligrams of methadone, most likely that is for opioid use disorder. Okay, if I heard that in my clinic, I don't know what I would do for them. I'm not an addiction specialist. Okay, when we use methadone for opioid use disorder, they must go to a methadone clinic. Meaning they go to this clinic every single day, they check in, they get their dose, they drink their dose in front of their provider, they leave. It's very time intensive to make sure that they get the ride, they go there, all this stuff. The benefit is that it is that one-to-one, right? It's just prescription heroin if they were using other illicits prior. So it's just a one-for-one switch as far as mechanism from a full agonist standpoint. We cannot prescribe methadone for opioid use disorder. We can prescribe methadone for pain. Methadone comes in a variety of different routes. Its half-life is anywhere from 8 to 60 hours. Not super helpful, right? Do you have to take it 3 times a day, or do you take it like twice a week? Right? So we know that as long as someone continues to use methadone, that duration seems to increase. For pain, we typically dose it every 8 to 12 hours. Peak effects are going to be delayed. So it's going to take 3 to 5 days for them to get to peak effects of methadone therapy. So because of the super long half-life, it's naturally a long-acting therapy, and so we have very minimal withdrawal effects, which is why it is helpful in situations like opioid use disorder. It's really helpful when we're trying to get someone off of opioids to first rotate them to methadone and then dose reduce, because they won't have as much of a withdrawal picture. The dosing, I initially had it here. I'm just saying at this point, it's complex and refer to an expert. Okay? Or ask someone to educate you on it so you can use it safely. Again, its metabolites are all inactive, and so our biggest concern are whenever we're inhibiting the metabolism of methadone, increasing that risk for different accumulation and withdrawal. Side effects, like we mentioned, serotonin syndrome, QTC prolongation is another concern that is dose dependent. And then the CDC guidelines actually have a little snippet in here essentially stating that this should not be the first choice, and only clinicians that are trained to use methadone, given its unique pharmacokinetics and risk for QTC, should be choosing methadone. So let's say we have Kenny. He's admitted to the hospital. He has an exacerbation of his pain. It was previously managed with methadone 5 by mouth 3 times a day. Despite yesterday, the team, they increased it up to 10 3 times a day. His pain is still poorly managed, and the team decides today to increase it to 15 TID. Your bad idea. Why? Yeah, it takes a while for it to get to steady state. Right? So we fully expect those first 3 days, we're sorry, Kenny, it's going to suck. Hopefully around day 3 to 5, you start to feel the effects kick in a little bit more. Right? So during that time, you do that initial increase, you're just doing a lot of breakthrough meds. Right? Here's some oxy, here's some hydromorphone, whatever you need, Kenny. We're here to help you for a few days, and then that methadone is really going to start getting to that new steady state. At that point, we can then increase.
For someone using methadone like that, man, and then you're doing the breakthrough pain, the opiates, do you need to dose down because they're already on methadone?
So do we need to dose reduce breakthroughs if someone's on methadone therapy?
Or if somebody was on methadone and relapsed, and like, would they be more prone to an OD because they already have methadone in their system?
I'll try my best to answer it. Ask me if I'm not answering it correctly. So methadone is a full agonist, right? It's going to act at those receptors. It acts for a very long time. So the benefit, someone takes methadone, they're on it for a while, it's fully activating those things. If I don't show up to methadone clinic for a week, my methadone levels will drop, right? I'll go through a amount of withdrawal, okay? If I go back to methadone clinic, we would need to dose reduce at that point because we wouldn't want to go back to an overdose state, okay? As far as breakthrough therapy, in addition to methadone, there's no necessarily nuance between those things. One is the ocean, one is just the tidal waves. How can I clarify further?
Considering that patient's age, would we still want to use
Good question. So given his age, would we want to use methadone? So certainly good question. I think, so this is semi-based on a real case. There's reasons why methadone was probably chosen for a patient if they're on methadone. I don't think I'll be asking specifically for you guys to determine, like, is methadone appropriate, unless I'm saying, like, we're starting everything that is a drug interaction. Should we keep methadone, like, so is it appropriate in this specific patient if they have needs for all those different mechanisms, right? If they have neuropathic pain, if they have an opioid-needed pain, if they have an antidepressant-type pain that we can treat with all those mechanisms, methadone can be really, really helpful in that patient. Good question. Yeah.
Is methadone one of those drugs that we should do it like go slow and
Yeah. So methadone dosing, the guidelines that were published are 2013-ish. There was a new white paper, which is just an expert opinion statement, that was published in 2019. And so that's what I use a lot of my guidance based off of. But it's a methadone white paper, and this dosing approach is actually aggressive based on that. So increasing by no more than 5 milligrams every 5 to 7 days from 0 to 30 milligrams. Okay, so once their total daily dose is 30 milligrams, which he was at 5 kg, so he's only at 15. We doubled it, essentially. So that's incorrect initially. Again, I'm not asking you guys to know that dosing piece. Then beyond that, we only increase by 10 milligrams every week. So this is a very aggressive dosing. A similar case that we had, this happened, the patient ended up dying on day 5. So, very concerning. Other questions? Cause of methadone-related overdose is not going to be respiratory depression most commonly. It's going to be QTC prolongation. So they die of torsades. Other questions? All right, now we're going to talk about bupe. I know that we're getting to the top of the hour. I want to finish bupe for sure. We'll get through it. Bear with me, guys. Alright, so bupe is a C3. Okay, that's a unique thing. Tramadol was a C4. Codeine was kind of a mix based on what it was. So bupe is a C3, meaning that we can put refills on it. Yay! Love refills. We have a handful of different mechanisms. So we're a partial agonist at mu, right? We're only letting some of that effects in at mu. We're an antagonist at delta, we don't really know what that means. And then we're an inverse agonist at kappa. We also have some of that NMDA benefit. So the main thing, that partial agonist at mu, when it's binding to these mu receptors, we have a reduction in receptor phosphorylation. Fancy way to say that this phosphorylation process is why we get side effects from opioid therapy. So because we're only opening it so far, we have less side effects associated with bupe, is the bottom line. Why we still maintain that pain. It is also the highest affinity to the mu receptor, meaning it is going to be a magnet onto that receptor. It's going to kick everything else off. It's so much stronger to that mu. Okay? That means that if someone is on high dose bupe, it is always going to kick everything else off. And we're not going to use anything else. If you have surgery, if you're in a car crash, too bad. So sad. Okay? So highest affinity, it's always going to kick there. So whenever we're at doses greater than 16 milligrams a day, we have potential to kick other things off. So why do we care so much about bupe? So the VA guidelines actually say that if we have to use something for chronic opioids, someone's been on opioids for over 3 months, if we have to pick something, pick bupe. And that is because it's safest. It has that partial mechanism. Its half-life is longer. It does go through 3A4, and it also has QTC prolongation. When we're looking at the different products, so we have a patch and we have a buccal film. Those are going to be the only two that are micrograms and are the only two for chronic pain. So whenever we have low doses in micrograms, it's going to work for pain because we only need to hit 5 to 10% of the receptors. So we hit those receptors, our pain is well managed. For moderate dosing, so anywhere from 2 milligrams to 16 milligrams, now we're inhibiting cravings. We're just occupying those receptors. Okay, we're also treating pain if someone had pain as well. High doses, greater than 16 milligrams, are going to occupy over 80% of them and are going to block the effects of other opioids. So hypothetically, we have a candidate who comes in and is going to get surgery. So if someone has minimally painful surgery and they're on bupe, what do we need to do? It's a non-painful surgery and they're on bupe. Do we have to dose adjust anything? Are we worried that we're going to inappropriately manage them? No. So we just say continue what you're doing. Okay, so that word is continue. Okay, if someone has painful surgery, your 2 questions are going to be, are they on low dose or high dose? Don't know what all these other boxes are. So low dose is on the far side. Okay? If they're on low dose bupe, meaning less than 16, what are we going to do? You're going to tell them, like, so sorry, your pain's not well managed, deal with it. Are we worried that it's going to kick other opioids off? If they're on low doses. No, so we just continue. No change, do what you're doing. If they're on high doses, our next question is going to be, is it, I don't know what's going on. Is it emergent or is it elective? Okay, did they just get in a car crash right now? Or are they coming in to get their hip replaced? Can we delay it? If we can delay it, what is our approach going to be? If they're on, let's say, 20 milligrams a day. Yeah, we're going to dose reduce, try to get down to 16, have a little bit of a washout, and then have the procedure. Okay, so get them down where we can still give them meds on top of it, and we're good. If they were just in a car crash, we're probably going to intubate them. I apologize for how this slide looks. We're probably going to end up intubating them and giving them a ton of opioids. Okay, so we're going to overdo it. We're going to do an ICU admission, all the things. Okay, bear with me, 2 more slides here. All right, so Noah, 31-year-old, has opioid use disorder. He's currently getting bupe 24 milligrams a day. He's scheduled to get a colonoscopy because a family member also had an early polyp, and he is not happy. What are we going to do for Noah? Do we care?
Gotta give it some time. Let him stop it.
Okay? So our colonoscopy is painful, just emotionally, right? So likely we're fine, right? We can say, you know what, Noah, so sorry. Sorry you have to do this. Here we go. If it's a painful procedure, okay, if he was getting his knee replaced, what would we do? Dose reduce down to 16, have that little window, then he can get his procedure done. Okay? So clinical paroles on all of our opioids, remembering our metabolism and excretion and how all these things are connected, thinking about that interaction that may be going on. Many opioids exhibit additional mechanisms beyond that mu receptor, and then short-acting opioid therapies usually peak and have their effects within an hour, and then long-acting therapies will take days, hours to days to reach those full effects. Okay? On Monday when I come back, we'll talk about opioid dosing considerations. We'll do that conversion quickly. Again, you guys